All right. Hi, everyone. It's great to see you, and I'm glad that you are with us today. We're on our, I guess we're on our 6th week of our training for Introduction to Palliative Care in refugee camps in Kenya. It's great to see all of the participants with us today, and we have several faculty as well. So if you're looking for a faculty member, I've changed our names to hashtag and then the name of the faculty. So if you wanted to reach out to someone or you want to try to connect during the call, those are all the people that are faculty here today. And my name is Erin. I'm a registered nurse from Canada, and I'm currently based in Kenya, in Nairobi, and I'm helping lead this course. But it's great to see you. And just a reminder, if you are able to stay on mute just while we're doing our presentations, and then we'll have plenty of time for discussions and questions. And because we have several faculty with us today, if you do have particular questions that you'd like to put in the chat, you can do that, and then they will be monitoring the chat. And yeah, I will be presenting today, and just let me share my screen. Today, we're going to be talking about spiritual, psychological, and emotional support for refugees living with life-limiting illnesses. And of course, you as the frontline workers in Dadaab refugee camp here in Kenya are going to be the experts at this, but we do have a few tips and topics that we want to talk about. We do want to focus on this particular topic with a trauma-informed approach. It might be a new topic for you or a new concept, but a trauma-informed approach is really important as we provide care to refugees and to people that are living in humanitarian settings. So for today, I'm going to describe to you what trauma-informed palliative care is. Then we're going to look at a stepwise approach to this type of care. We're going to talk about some common ways to help people that are in distress or experiencing trauma at the end of their life. And then finish with describing how to support patients and families spiritually in palliative care. So when we think of the word trauma, I want you to think of an event or possibly a series of events that could be physically or emotionally harmful for a person. Sometimes trauma can be life-threatening. We know that trauma can be conflict. We can have trauma, conflict within families, but also political unrest and war can also cause trauma. If someone has become a refugee, the chances are it is because of some sort of trauma, either conflict or climate change or a natural disaster. And this is something that I think many, if not nearly all of your patients that you're taking care of probably are or have experienced at some point in their life, or someone in their family would have experienced. So when we think about palliative care, we do actually want to do this with a trauma-informed approach, because we need to realize that when we go to the bedside, or maybe we're in an outpatient clinic, the patient and the family that we are taking care of probably, again, has experienced that trauma. And we need to make sure that when we are asking them questions, when we're assessing them, when we're communicating with them, we remember that they have experienced traumatic things in their life. And it is most likely going to affect their perspective on a serious illness. It's going to affect their reaction to possibly getting difficult news. All these things are greatly impacted when we do palliative care for someone who's experienced trauma. So we know, especially for our situations in refugee camps or humanitarian settings, that treatment of patients can be difficult because we often have limited time. Sometimes patients are the traditional treatments that we have for someone experiencing trauma or someone who has a life-threatening illness. Seeking mental health can be difficult. We know that this treatment sometimes takes 8 to 16 weeks, and therapy is long. Therapy sessions often are long, sometimes 50 minutes, sometimes even 90 minutes for someone who's experienced severe trauma. And we know in most of our settings, we don't always have this time to provide for our patients when they really need it. So for palliative care, and when we try to intersect palliative care and trauma-informed care, we can see that the illness actually can be considered the primary traumatic event. So if you have a Somali woman in the refugee camp who has experienced being a refugee, she's fled to the camp several years ago, her family is with her, maybe some of her loved ones have died over the past several years. And then she was diagnosed with breast cancer. This new diagnosis could actually be a new trauma for her. We know that past trauma, such as war or genocide, these memories can be reactivated when patients are closer to the end of their life or when they are diagnosed with a serious illness. And this is something that we need to really think of, and something we may not have learned during nursing or our medical training. And this is something that we hope from today's session that you will be able to think about. I know that for humanitarian workers and often healthcare workers working in refugee camps, we can become kind of jaded towards the trauma or towards the stories of each individual refugee, because we are dealing with so many people that have a similar story. But it is really important, especially for those of our patients that have a serious illness, that we take this into consideration. So I want to introduce to you a case. So this is a 55-year-old a woman who was recently diagnosed with ovarian cancer. She shared that she has reported fear when trying to fall asleep at night. She often describes flashbacks or nightmares related to the genocide and the history of abuse that she's experienced. And we realized that actually she's missed her last 3 clinic appointments. So as we think about this case, I also do want you to think about the patients that you see in your clinics or the people that you see in your inpatient settings. They may actually also have a similar history or a similar story. What do we do? How do we start thinking about caring for a patient like this? First, what we can do is recognize that this is a trauma, a distressing memory or an intrusive thought, or avoiding clinic appointments or avoiding talking or communicating with healthcare workers is a sign that the person has experienced a trauma, and it's very difficult for them to deal with it. It's really important that we, as the providers, listen. We sit down, we pull up a chair or find a place that is fairly quiet where we can listen and talk. It's really important that we express empathy. We've talked about this a lot, about communication within palliative care. But one of the things you could say is that I can't imagine how difficult this must be. I can't imagine how scary this must be for you. These are ways that we can show that we care and that we are trying to be empathetic towards their situation and what they're dealing with. We know that serious illness and PTSD, or post-traumatic stress disorder, are serious things that we need to consider. So someone who has experienced PTSD, which again, most refugees or patients that we would be taking care of may have this situation or may be experiencing this. We know that it can be difficult for them to cope. Making medical decisions is not easy. We often notice that people functionally decline when they have these kinds of diagnoses. And sometimes their medications are affected. Some of these patients also experience pain. So we know that there's a lot of commonality between these two situations. And within the scope of palliative care, we will come across patients that are experiencing these things. So what can we do? What are some things we can do? Of course, when we are learning new things, we try to make it as simple as possible so we can remember. So today I'm going to teach you a stepwise approach to this sort of psychosocial palliative care or trauma-informed care. So the first stage, so if you look up there at the top where the blue is, the first stage is to palliate immediate discomfort. So we want to make sure we assess and we manage their symptoms, and then we provide social support for our patients. So we can do this by, number one, developing a trusting relationship by the active listening that we've talked about. We can express empathy. We can have an empathetic response towards them, and we've shared some examples of that previously. And we can also do our best to change the physical environment to make sure that they're as comfortable as possible. If this means maybe rearranging the ward area so that someone who has a serious illness and is in extreme discomfort, maybe has access to a window, maybe we arrange for a curtain or a shade for them so they can have some privacy. We can try to do some small things to provide them some support and palliate their immediate needs. The next thing that we want to do is we need to provide some psychoeducation and try to help them enhance their coping skills. So we do this by educating patients on medication, their care plan, what are some of the things that we're doing for them to manage their symptoms. And then we begin to slowly, in a culturally appropriate way, talk about dying or the end of life process, what they can expect and possibly experience if they are end of life. We do want to help patients with specific techniques for coping. So these can be things such as relaxation or breathing exercises. And this is something that you can do on a regular basis and remind patients to do. You can actually do it with them. And then the final stage is to try to treat the specific trauma. So we would do this with the support of our mental health providers or the clinical psychologists that we have access to. And if you feel like in your situation you don't have access to, even through this small group that we've created through this Project ECHO, we, I think, have quite a few resources where we can provide the pain and symptom control, the psychological, the social, as well as the spiritual support for our patients and families. And this is really, really critical. So when we think of a psychosocial assessment, what is needed? So the problem is, little is known about palliative care and hospice assessments. Sometimes when we do psychosocial assessments of our patients, we think about their, maybe their social situation, where are they coming from? Do they have a history of abuse? Do they smoke? Do they drink alcohol? We do need to go beyond this for palliative care. We want to know we want to know things that most of our psychosocial assessments don't include. We want to know what a patient's physical or functional status is. We want to know what their preferences are for treatment. We want them to be aware of their diagnosis. And we know, again, that in many cultures, this isn't always easy or appropriate, but we do need to have a bit of an understanding of what is the patient, are they aware, and what are they aware of? Who in their family knows about their diagnosis? Do they understand their prognosis or how their disease is going to progress? We think also when we do psychosocial assessments in palliative care that communication and somebody understanding their health or being health literate is really important. And also, of course, understanding cultural values of a patient and their family. So this goes a bit beyond basic psychosocial assessment that you would do in a general medical ward. And it's really important for our patients that are experiencing serious health-related suffering that we do try to go in depth into our assessments. So who is the person in this case? There's a really interesting patient dignity question or questionnaire that is a simple open-ended question. It was written by Harvey Max. I'm not going to be able to say his last name correctly. Cho Chin No, maybe Megan can share with us later. He's a Canadian, I believe, and he wrote this. This is one question you could integrate into your practice in the future. What do I need to know about you as a person to give you the best care possible? What brings you joy? And as we try to get and understand our patients more and understand their psychosocial, their emotional, and their spiritual well-being, this is a really simple question that you could ask, and it allows a patient to open up and share so that we can give dignified care to our patients. So now we're going to shift into understanding what total suffering means. So when we think about total pain or total suffering, we think about different areas of that. And again, this might be a new concept to you. For those of us that have done some palliative care training before, you would be familiar with this, but sometimes people only think of pain as physical or suffering as physical. This type of discomfort, you can see there in the red, usually needs treatment, such as drugs, to be given to treat that. And it can be at a variety of degrees of distress, and oftentimes can interfere with other aspects of your life. So we know that patients that are in physical pain or experiencing physical suffering sometimes and most often also experience emotional discomfort. And that can be there in the purple side. This could be anxiety, depression, possibly frustration or hopelessness. And when patients experience this, we do know that it affects their spirit or their spiritual life. They can experience guilt, sometimes fear of what's going to happen after their death, or feeling a sense of connectedness. And all of these things are very interconnected. We know here in the blue is how our patients suffer socially. Sometimes they have distress related to family interactions or family members. They have possibly a loss of their role or their job. And sometimes they can't participate in social functions in their community because of their illness. And this is the type of suffering we know many of our patients experience. So Ratner and Berzoff in 2016 challenged healthcare workers to sit with suffering. And this isn't something that's very common to hear when we think about humanitarianism and medical care, but it is really, really important as we integrate holistic palliative care into the work that we do. And the idea is that oftentimes suffering is often intrinsic. So it is going to happen when patients are at the end of their life. We know that patients physically suffer, and we try to do our best to manage their symptoms, but there are things that are going to occur to our patients that we are not going to be able to fully remove or to change. And some of this allows us as healthcare workers to sit with those that are suffering in the clinics and the different settings where we work. So some patients might experience anxiety over their death or their anticipated death, some loss. They might feel a burden or a worry to their family. And many patients also experience loneliness. So now we go on to another case. And I want to introduce to you a 45-year-old female with ovarian cancer. She was admitted to the hospital with a small bowel obstruction. So her prognosis was quite poor. She was likely only going to live for a few more weeks. She had 2 children, ages 13 and 14. And the nurse reported that she'd been crying a lot and really worried about her children. She asked for social work and the chaplain to help. And this is quite interesting. So the amount of physical suffering probably would have been high. She would have been very uncomfortable. She's quite young, only 45, and her prognosis was poor. So her emotional and her spiritual suffering due to the age of her children and the worries and the emotions that she's experiencing really need to be addressed. What can we do to assess her distress? We can begin another idea for psychosocial assessment is to ask these questions. What helps you cope? What are you hoping for? How are your spirits or your mood right now? Are there things that bring you joy? And what do you think can help you cope? Again, here's some repetition there, but I think it's really important for us to understand our patients, especially those that are at end of life. When we do this type of support, communication really needs to be non-judgmental. We need to emotionally support our patients, validating their emotions by saying, it's common to feel like this, or I can't imagine how difficult this must be. We, again, need to manage physical symptoms. We've talked about this before. We can't get to emotional processing or even decision-making when a patient is in pain, physical pain. So what we can do, we can encourage them by asking what's worked in the past, offer counseling if we have access to that, and support the patient with self-care measures that they feel have worked in the past to help them cope with difficult situations. We want to encourage social support. So oftentimes the unit of care is the family. We know that in many of the patients that we take care of, we're not only taking care of them, but also their family and their friends. We know that serious illness can impact finances, income generation, education, as well as caregiving. Families often need information. So as you get more confident in providing palliative care, patients might ask you questions about what they're going to expect in the future. So how do you like to hear information might be something that we could ask patients. Maybe there's certain people in their family that like to be there when we share information, or maybe it's really important and that person always needs to be there. Maybe another way we can emotionally support people is identifying maybe they've experienced grief before. How did they cope in those situations? Is there a caregiver that we can support alongside the patient? And then legacy work is an example of encouraging and walking alongside someone as they prepare for their friends and family once they have died. So maybe that could be writing a letter or taking a picture or creating something for their family to remember. And then often we know that patients and families need practical support. So if someone is wanting to be at home or to leave the hospital, maybe identifying if there's nursing care that can be done for a patient. And we often do provide medical counseling, explaining medications and identifying any side effects that patients may experience from their medication. I do need to go a little bit quicker as we have a case from Dr. Megan that she's going to go through. And I will share these slides, but we know and we need to reduce the stigma related to depression and anxiety in our patients. So many of our patients with life-threatening illnesses that are not able to access any sort of treatment or curative treatment often can experience depression. And this would be a low mood, loss of interest in their activities, feelings of hopelessness. And here's some examples of different medications you can prescribe for them. And we also know these patients and patients that we see also can experience anxiety. So then there's also some examples of what you can do for patients that are experiencing those things. Depression is a clinical diagnosis, often identified by these symptoms. So this might be something that I can also share this as a PDF, but this might be something that you might want to print out and put in your area, your clinic area, because we sometimes forget what depression really is. People that have a history or at higher risk are people that have a history of mental illness. They might hide their emotions or have recently experienced bereavement or a loss. And then demoralization is a little bit different. It is a situation that can be characterized by a lack of motivation. Sometimes you have potential for joy or hope based on the different environments that you're in. But sometimes we do know that demoralization can be mistaken for depression. And it doesn't classically respond to medications the same way that we treat depression. So it is really important to identify if someone is feeling demoralized or if they do have a clinical situation related to depression. And now I'll just finish with spiritual distress. So how can we assess someone that could possibly be in spiritual distress? We can ask them questions. So you could ask them, do you feel at peace? We know that spiritual well-being can be understood as a feeling of peace. Spiritual distress occurs when people are unable to find their source of meaning or hope, have peace, comfort, or strength and connection in their life. And this distress we know can often greatly affect physical and mental health. Terminal illness can cause this type of distress in patients, and we know it can also cause distress in our families and friends of the patients too. This is really important that we identify this in our patients and share with the care team if this is happening. This is the way you can assess spirituality, and it's an acronym called HOPE. So I'll let you review that afterwards, but these are different things you can ask patients as well. It's really important as we support our patients spiritually to listen to their story and show compassion. We don't want to give advice all the time or impose our beliefs on other people. But one way to do that or avoid imposing our own beliefs is saying, tell me more about that. Or what does it feel like for you? We do know in palliative care, though, we need to avoid giving false assurance about a person if they are talking about death and dying. And it is important, again, that we sit with them while they're sharing these things and while they're thinking these things. because we know that meaning can be found through these interactions with family and friends, possibly creative activities, or support from a religious or spiritual leader. You might have heard of the word grief, and there's different ways to teach and understand grief. But this is kind of the reality of most people's grief. It doesn't go in a straight line, and we know that there's many different aspects of it. And we want you to be able to understand that every person's grief is a bit different, and different things will cause people to have grief in different ways. There's no one way to grieve. There's no right way to grieve. It doesn't travel in a predictable path. It doesn't disappear. It actually just changes. Although sometimes we feel like as medical professionals, we need to fix people's symptoms or fix people's grief, it's our job to sit with suffering and support people while they're going through these situations. So as we finish for today, psychosocial distress, things like depression and anxiety are very common for patients that we take care of. Palliative care can provide support for these patients by offering information, giving emotional and practical support. And it is important, if our patients are experiencing spiritual distress, this can impact their physical and mental well-being. We need to listen and allow our patients and families to identify what they think can help them during these times. And I do want to remind you that there's no one way to grieve. And it's important, and it's our job as palliative care providers and humanitarians to sit with the suffering of our patients and walk alongside them. And here's some references for the talk today. Thank you. We'll allow for a few minutes of questions if you have anything particular, and then we'll go into our case discussion. I know that a few people joined during the session, but does anyone have a question or a thought about the topic today for emotional and psychological support for our patients? Do you guys find that you're providing this type of support, or is it difficult and you avoid these situations because it's too hard? Gabriel, do you want to share?
Hi. For starters, we don't reach that point. Let me start from there. Because number one, when we get our patients, when we get to the psychosocial aspects, the spiritual components, we have a lot of religious-based beliefs. And when the patient is severely sick, and you start questioning or you start suspecting, because most of the time it's suspecting that you're dealing with a palliative case, the family always insists on Quran recitation.
Okay.
So, and most of the time what we do, we try as much as possible to incorporate the Quran recitation, try and educate the family on the importance of this, because it's their culture, and very important, especially on someone on palliative care. We need to see how we can involve their beliefs as well as educate them on how to support the patients. So most of the time when it comes to spiritual aspects, we always find ourselves, we only educate the family on what is, how to do the spiritual support. Because sometimes the Quran recitation might involve a bit of beating, and that might harm the patient more. So most of the time, it's to educate the family on this.
And who on your team provides that? Does someone come in, or is there an imam on your team with MSL?
We are trying to work on a project that will try and incorporate the religious leaders into our services. But currently what we do, we give them some time. So what we've done is, when they are in the ward, when they need spiritual Quran recitation, We allow them to go for the Quran recitation and then come back to the ward. So at the moment, that is the best we can support them at the moment. But these are projects that we're trying to work on to see how we can incorporate religious leaders into our services, because spirituality and mental health, they go hand in hand. You cannot separate the two.
Yeah, I think, thank you for identifying some of the more common religious beliefs and the things that bring comfort to people that you're taking care of. I think it's really important that we do identify what are the religious beliefs, and then maybe today some of the things might be new to you in terms of how we can assess and support people spiritually in collaboration with their religious belief, because I think regardless of what religion someone has, as they approach the end of their life, they will experience different emotions and experience distress in different ways, whether they're Christian, whether they're a Muslim, whether they're strong in their faith, or whether it's more cultural. Ali, do you have any comments? Ali Hamis.
Good afternoon, Erin.
Hey, Ali.
Very fine. Mine, I don't have currently more comments, so I think we are expecting to improve also the quality of care, mental health in our. We usually refer patients to the clinic in IRC, Department of Mental Health. When we receive patients who need this, who are psychiatric patients, we normally refer their mental illness patients. So we have a nursing officer in charge of mental health department who normally deal with them.
Nice. Okay, so it sounds like there are some things that you guys are implementing. So why don't we shift on to the case? Megan, I think you can share your screen. And if you have any further questions, we can put it in the chat, and I'll share, after the session, I'll share some of those resources with you as well.
Thank you, Erin, for that. That was a very comprehensive overview. And about how much time would you just like me to keep my session to?
You
so
can,
I make sure
you can do 15 or 20 minutes. We usually go 5 minutes over. So yeah.
Okay, perfect. So this case, I mean, Erin shared a couple cases, but this is just another case. And in this case, we'll like actively discuss it together as we go along. So I'll present a little bit, and then there'll be a chance I'll ask you guys a question, and then you can either share by unmuting or putting your answers in the chat. So this is another young woman. She's 32 years old, and she has cervical carcinoma, and she has some metastatic disease at the time of diagnosis. She has some lung and bone mets, and she has severe bone pain, and she's been receiving some IV morphine. She's in the health facility in the hospital. She's married with a 4-year-old son, but since having the diagnosis, her husband has left her. She stays in the refugee camp with her mother, who is very elderly, and her younger sister and brother. Her younger sister is taking care of her child while she's in the hospital, and her brother is staying with her at the hospital to help care for her. When you see her during the day, the nurses tell you that she's like screaming, she's crying out, she's disturbing the other patients. She seems like very, very distressed, and the nurses think that maybe she needs like more psychological support. She wants to leave the hospital, she says, even though she's like having very severe pain, and she needs the IV morphine, which she can only get while she's in the hospital. The oral morphine wasn't working for her, wasn't being absorbed. She still was having a lot of pain. That's why she came to the hospital. But somehow she wants to leave, even with the need for the IV morphine. So in terms of the communication that's already been done, the patient and her brother were informed about the diagnosis and prognosis. and that it wasn't going to be possible to treat her for cure. And then she shares that when she's in the hospital, she has some memories. It brings back memories of attacks on her village in Somalia. She's very frightened of the hospital guards because they remind her of the armed forces. They're wearing uniforms. And so at night, when it's dark, when it's more quiet, that's when she's really feeling scared. That's when the attacks happened in the past. So she feels out of control. She's like crying and screaming and hitting her bed and kind of having what we would call like flashbacks or reliving the experience of the trauma she's had before. So when you think about this patient, I've described a little bit about her, and maybe you are coming to see her. What would be some things that you would think might cause trauma for her? And there are many, many things. So we're just going to stop here for a moment, and please share some of your ideas about what might be things that are traumatic about her experience right now. Doris has said her past experiences. Yeah, definitely. That's a source of trauma for her. And you don't have to necessarily like ask her to tell you everything, right? Because sometimes that what is recommended is just to know that the patient has had trauma, but you don't have to get them to tell it all to you again, because that's traumatic for them. Her husband leaving her. Yeah. So we see this very commonly. Loneliness. Yeah. She's away from her mother, her child, pain, hospitalization, past war experience. Great. Really good ideas that people are sharing. Her husband leaving, having a small child. So even being young and having cancer and having a young child, that's trauma, right? Because people, when they're a parent, they're more traumatized by being ill and thinking that they will leave their child, after they die, their child will be alone, their child won't be cared for. That's a source of trauma. Anxiety. Good. I'll show you some of the ones that I had come up with, but of course, many more that you guys have listed, even more, I think, than what I had put here. The healthcare and the illness itself. So cervical cancer can be traumatic because the examination and the physician looking at the cancer, just having that exam done might be traumatic for the patient, especially if they've had experiences of sexual violence before. The pain, the loss of control with the illness, the loss of her husband, missing her son. We talked about all these different things that can be sources of trauma. And so now let's think about how we can assess her, her spiritual and distress, and how we can support her. And what can we do to help? So again, here, I want you guys to think about some of the things Erin shared, and what do you think we can do to help her, knowing all these sources of trauma that we've talked about she might have. So it seems like a lot, you're thinking like, I'm not trained, maybe, not many of us are not psychologists or psychotherapists or counselors. So, I myself, I'm just a physician. So sometimes it feels scary to think, what can I do to help her? Like, she has a lot of, source of trauma. So what are some things we can do, even if we're not like experts in psychological support? Does anyone have any ideas? What can we do? Based on what Erin said. Sit and listen to her story. Yeah, that's really good, right? So you don't have to know what to do to fix. You can just listen. Just acknowledging that the patient, has had a difficult life, that it's been very hard for her. Spikes, communication. Yeah, I'll show you one idea that I find very helpful to think about it like this. Just 3 things you can do. You can just develop a trusting relationship, like what people are sharing, just by active listening. So just, and I know you don't have a lot of time, but even if when you come to her, you just give her 5 minutes or 10 minutes where you actually sit and listen and just say, I'm here to hear what you have to say. What do I need to know to care for you best? Like that question that Erin mentioned from Dr. Chachanov, the dignity therapy question. That is very supportive for patients. If you just say, I want to know what I need to know to help you. And then the patient feels like they've been listened to and heard. And then we can, the second thing is to express empathy. And that's just to say, I see that this has been very hard for you. This must have been very hard. And you can think about how best that goes in the language that you're speaking to the patients in. You might want to think about, like, how do you translate that kind of a phrase from English? What's the best way to express it? And then if there can be any changes to the physical environment. So trauma is often triggered by the physical environment, right? For her, she's triggered by the guards who remind her of a militia. And we see this very often, that things will just trigger the patient. If you have experienced sexual violence and now you have cervical cancer, like, just that could trigger because of, that experience. So if there's anything we can do to reduce the physical environment from being a trigger, or understand how it's a trigger, that can help. Just want to go back. One thing. Few other ideas is just recognizing that the patient's had trauma. So one thing that they recommend is that we sort of tell ourselves, oh, this patient has had trauma. They need a trauma-informed approach to care, where we take into account the fact that they've had trauma when we care for them, and we change our expectations. Like knowing that the guards are going to be a trauma trigger for her, then maybe you make her bed very far away from that. You maybe, have the guard be outside the door so that she can't see that person. Talk about it with her, what would help her. Then we talked about sitting and listening. And here's some phrases for expressing empathy that are specific for her, perhaps. It's so hard to be away from your family. You could say, it's so hard what you're going through. This is so scary for you. This is so hard for you. If they've sort of said that, like, don't force it on them, but, you might say something like that. And then an idea for the environment would be, like, could she be cared for at home? Would it be possible? Maybe try again with the oral morphine, see if it's possible for her to be out of the hospital, be close to her son, be close to her mother. Yeah, and Doris, you just said, if it's possible, we can nurse her in her own home. Yeah, such an important thing. So those are the 3 things. Develop a trusting relationship with active listening, use some special phrases to express empathy, like just say, it's so hard, and then think about how you can maybe change the physical environment. Sometimes, like Camus was saying, we need to give spikes communication, so helping more explain the medical piece, because maybe they don't fully understand the disease and prognosis. So just finding out what they know and what they need to know. And sometimes we can, if we get more skilled, we can teach some coping skills like relaxation techniques, breathing exercises, encouraging prayer, spiritual support, and meditation. I won't go into these in detail, but these would be like the next things you could do. So that's the first case. I wonder if anyone has any more ideas for how we could help this patient before we go to the second case. Any other things you could do? Hi, Vilma, go ahead.
Hi. So I'm sorry, I missed a little bit, some bits here and there, but I wanted to ask you if, as part of what you talked about, was it mentioned that, at least from my experience, when it's young mothers, there's a huge distress around the kids forgetting them, right? So it's maybe, you mentioned legacy work before, or doing something for the kids. So leaving that, like life history, pictures, cards, things like that, that you can, it gives some peace to the mom. But I don't know if you talked about this before. I mean, we could talk about this for a long time, but it's something that I've seen that helps relieve that distress.
Thank you. That's a really good suggestion, and we haven't talked about it today, so I'm glad you brought it up. The idea of making sure that you're remembered, legacy. Is that something that is familiar to our participants, or do you see that with the mothers, if they're a young mother with children or a young father with children, that this is something that they're interested in, is to make sure that they're remembered, like leaving photos or a video message for their children? Have you seen that at all from any of our learners, any of our participants? Annalise, is it something you guys have ever thought about or experienced? Sure.
Come again, me.
Just so if you have a patient who has young children who's dying, like this lady in this case, she was 32-year-old and she had a 4-year-old child. Then Vilma's saying about one thing that helps with distress for these kinds of patients is they don't want their child to forget them. They're worried they'll be forgotten and they won't be able to like kind of be part of their child's life after they've died. So Vilma was saying about allowing the patient to have some photographs, make some items, maybe some memories, something that then the child can take and keep, and it will be like a memory of the mother. Have you ever seen anything like that done?
I think my network is not good. I know. But
I'm not able to.
We could ask,
I've come across
yeah, go ahead, sorry.
I've come across such a case where the mother, although she was not young, but she had lost most of her children, and she was remaining with one child out of 9, and she was dying of cancer. And she really wanted the daughter to keep memory of her, so she gave her one of her best clothes that she should not give out that one, she should remain with it. So that is how she kept. But she at the moment of her death, she was happy, she was comfortable, and she appreciated the care the family gave to her and the healthcare team.
That's a great example.
After a long journey of 2 years.
Thanks for sharing.
Does anyone else have any examples they want to share of something like that? We call that legacy. Like if you're the one dying, making sure that there's something tangible for you. Any thoughts, Erin?
Yeah, Barbara, do you, I know Barbara is one of our leads on the call. Barbara, do you ever find that people begin to feel a little bit comfortable about death, or is it really most people avoid talking about it and therefore can't plan?
So my experience so far is, at least in the camp, is not very hands-on with the patient. So I don't have as much experience as Annalise would have, for example.
Yeah.
But for the patients who have been, even for short-term illness, people appear to be quite accepting of death. I think it's a more of a spiritual thing that the religion teaches that it should be. I mean, death is part of what God has willed for every one of us, and when the time comes, we shouldn't question, we shouldn't fight it. But that said, there are the some cases where, especially for children, where the parents might want to push us to try as much as possible, no matter how difficult or how bad the prognosis is. They're still willing to keep the patient in the hospital and hold on. But in many cases, in my experience anyway, when they feel that a patient is close to death, they actually just take them out of the hospital because they feel like they're not able to help. Like the death is coming, so it's like an accept and move on. And I like what you mentioned, that there's that sense of apathy that we can have here, because we've seen so many people who suffer. So many people with chronic illnesses who we can't do really much about. And it's easy to become desensitized to their pain and what hurt they're experiencing based on seeing their loved ones suffer. I think that's very important, because we have a lot of these cases that are beyond us and we really can't do much. And because of our perception that these are resilient people, they've been through so much trauma, they've been through very, very difficult times, experiencing war, having to traverse those dangerous territories to get to Kenya and settle. We forget very often that they're human beings and they experience these painful emotions, and that we need to support them. So that, I think that's my key takeaway from this class, is we have to be sensitive to them and give them as much support as possible.
And sometimes I think
we have had requests also for spaces for the patients to have spiritual interventions, for example, in our maternity. No, go ahead.
I think there's a very big delay.
I think there's a delay. There's a network issue in Hagadera, so you're hearing me much later than I'm speaking.
Yeah, I think I definitely agree. There may be our medical and our nursing line might feel like there's very little that we can do for these situations and these people, but even like you were saying, maybe just the space, the environment, what are things that we can do, and giving people a place to talk. Sometimes we don't feel like we have time, but someone who has experienced severe trauma and now has a life-limiting illness, trying to find ways and schedule time to spend with them. Thanks.
Okay, well, I think I'll wrap up there, because it's I don't have time for the second case, which is fine, but we did a really nice job discussing that one.
Yeah. Thank you, Megan. I didn't get a chance to introduce you. I'm sorry, Megan. Megan is a pediatrician from Canada, and she is specialized in pediatric palliative care. And she's one of our mentors through the Project ECHO program. She works mostly in Southeast Asia and Asia, including Bangladesh and Nepal and India. And we're really grateful that she's with us today. Megan is very approachable. She is extremely busy, but she is approachable. So if you are interested in learning more about pediatric palliative care, or if you have specific questions, she's always around, and sometimes on a different time zone than us, but she's around. So that's one thing that we want you all to know through this ECHO program, that we as faculty members are very much alongside you. We are not on top or anything like that. We are peers, and we are here to learn from you and engage with you. So although we're coming closer to the end of our course, we do hope that we can stay connected and maybe even have some of these meetings I keep talking about, trying to come up with the solutions to your chronic problems in the camp. But we will definitely do that. I think once we get the training kind of over and done with, I would love to set up a few groups and find some ways that we can start brainstorming together. And I know our faculty would love to do that too. Yo Dang, would you like to just introduce yourself? Yo Dang is one of our new faculty members. He's from Indonesia and he's a nurse and is quite keen on teaching. He's also a lecturer in Indonesia on palliative care. Would you like to say hello?
Yeah, hello.
This is our group that is based in Kenya in one of the refugee camps here. And yeah, we're looking forward to you being on our team.
Yeah.
And Doris, would you like to say hello? Doris is a nurse as well. Doris, correct me if I'm wrong. You're from Ghana?
Hello, everyone.
Hey, Doris. Do you mind sharing where you're from?
Hello.
Yeah.
Hello. Hello, everyone. Hello.
Hi, Doris. Maybe the connection is not so good. Doris is one of our new faculty as well. And I believe she is based out of Ghana. I think her connection is not so great. And most of you know, I think Annalise dropped off, but most of you know Ali. He's a clinical officer based in Hagadera. He's also our faculty member and has been very committed to the program. Vilma is a social worker based in, or care coordinator based in Canada. And again, if you need to reach any of us, please don't hesitate to connect. Obviously, I have everyone's contact. So if you need someone's contact, just message me and let me know. And we will finish there for today. We are meeting again next Thursday with our last class. It will be a new topic on neglected cancer care needs for patients in Kenya in the refugee camps. And Dr. Omar, the oncologist that's working out of Garissa, is going to be the speaker. And I'm quite curious to hear him and to have that discussion, as I know that we've been talking about a lot of these concerns each week. But thank you for being here. And it's really great to see all of you. And we'll see you guys next week.
Bye. See you. Thanks. That was great.
Thanks, Vilma.
Thank you.
Bye. Thank you, Megan. Thank you, Erin.
Have a
Bye.
good week.
Thanks,
See you next
everyone.
week, I hope.